opposite of bar diverticulum. It is Meckel's diverticulum. Why Meckel's diverticulum is just opposite? First, it is single. Second, it is true because it contains all the three layers: mucosa, submucosa, muscularis propria. It is congenital. And what is the location? If you see the location is along anti-mesenteric border. Clear? Now see the development. Meckel's diverticulum is the most common congenital abnormality of midgut. Clear? What is the problem here? These patients are having persistent vitelo-intestinal duct. What is the other name of vitelo-intestinal duct? That is also known as omphalomesenteric duct. Clear? Now, the question which is frequently asked in exam, that it is characterized by rule of two. Right? So what is this rule of two? Meckel's diverticulum, it is seen in 2% of population, length 2 inches in length, located 2 feet proximal to IC junction, and symptomatic patients are less than 2 years of age. Now what is the application of this knowledge? Have a look. It is located 2 feet proximal to IC junction. Sometimes patient is coming to you with signs and symptoms of acute appendicitis. Clear? Whenever you are planning appendectomy, you are performing the appendectomy, you notice that the appendix is looking normal. If appendix looks normal, then we have to rule out the presence of Meckel's diverticulum, and that's why we go 2 feet proximal to IC junction to locate whether patient is having Meckel's diverticulum or not. Right? Why? Because sometimes inflammation of Meckel's diverticulum can present as signs and symptoms of appendicitis. Clear? So that's why it is located 2 feet proximal to IC junction. So if a patient is having appendicitis, on exploration appendix looks normal, so we have to look small bowel, we have to check the small bowel 2 feet proximal to IC junction, and we have to rule out the presence of Meckel's diverticulum. Clear, guys? Now what is the problem in Meckel's diverticulum? You know that there is presence of ectopic mucosa. So this is the diverticulum, you can see here. And here there is presence of ectopic mucosa. So you must be knowing that what is the ectopic mucosa? It is gastric most commonly, followed by pancreatic, followed by colonic. If there is gastric mucosa, so obviously this gastric mucosa is secreting what? It is secreting A. Yes, it is secreting acid. And because of this acid secretion, what will happen? Patient is going to develop ulcer. So since there is acid secretion, there is development of ulcer. And if there is development of ulcer, so obviously what will happen? From this ulcer, bleeding will start. Clear? So what is the most common symptom of Meckel's diverticulum? You can see the most common symptom, it is bleeding. Most common symptom, it is bleeding. Now, what is the most common symptom in adults? See, any patient who is having ectopic gastric mucosa, that patient will be having ulcer. And if ulcer is there will be bleeding. If patient is not symptomatic during childhood, it means what is not there? There is no ulcer, it means there is no ectopic gastric mucosa. So, adult patients, they develop abdominal pain sometimes because of intussusception, because you know that Meckel's diverticulum, it's a lead point. You know that Meckel's diverticulum, it's a lead point for intussusception. So because of this, there can be abdominal pain. Sometimes because of diverticulitis, there is abdominal pain, and sometimes there is a band. What happens? There is a band connected from here. So band is connected from diverticulum to the umbilicus. Clear? And it is going to twist or it is going to turn. It leads to volvulus. So three things. Intussusception, there can be diverticulitis, and there can be volvulus. Because of this, patient is going to develop what? Abdominal pain. Clear? So what are the causes of abdominal pain we discussed? Midgut, volvulus, intussusception, and diverticulitis. Okay? Now coming to the investigation, let me tell you basics. Usually, for anatomical disorders of GIT, we go for barium study. If patient is having esophageal diverticulum, we go for barium swallow. If patient is having gastric diverticulum, we go for barium meal. If patient is having small bowel diverticulum, we go for enteroplysis or barium will follow through. And if patient is having colonic diverticulum, we go for variant knee. Clear guys? But what is the unique thing in Meckel's diverticulum? Unique thing is presence of ectopic gastric mucosa. So since there is presence of this gastric mucosa, we have to detect it. And if there is this gastric mucosa, how we can detect it with the presence of with which investigation? Technetium per technique scan. So by technetium per technique scan, we detect gastric mucosa. One question. Second question. Imagine a patient in whom there is absence of ectopic gastric mucosa. So obviously you cannot detect it by technetium per technique scan. So just like any other small bowel diverticulum, you can diagnose this condition. You can diagnose this condition by what? Enteroclysis. Clear? So you can diagnose this condition by enteroclysis. So if there is gastric mucosa, we diagnose it by technetium per technique scan. And if there is absence of ectopic gastric mucosa, we detect it. So investigation of choice, that is enteroclysis. Clear guys? Now coming to the treatment. Two situations are there. Imagine first one. Patient is having unhealthy base. See here, there is presence of ectopic gastric mucosa. So the patient is having ectopic gastric mucosa. Because of this, what will happen? There is ulcer here. And if there is ulcer, in that case, apart from the diverticulum, I have to resect the bowel also. So this is what resection and anastomosis. So who are having unhealthy base, patients who are having unhealthy base, in that case, what we go for? We go for resection and anastomosis. And the patients, here you can see this, here, there is no ulcer, there is healthy base. So you just excise the diverticulum. In surgery, if you excise something, that is ectomy. Like you excise spleen, splenectomy. You excise appendix, appendectomy. You excise gallbladder, cholecystectomy. If you give incision on something, that is otomy. Like you give incision on small bowel, enterotomy. On CBD, choledochotomy. On fistula, fistulotomy. Got it? So here we are just going to excise the diverticulum. And if you just excise the diverticulum, this is known as what? Diverticulectomy. Clear? So important point, make a diverticulum with healthy base, we go for diverticulectomy. And make a diverticulum with unhealthy base, we go for resection and anastomosis. Clear guys? Now, suppose any patient is having Meckel's diverticulum. Clear? What are the factors which are going to increase the risk of complications? So if there is narrow mouth, if there is unhealthy base, and if there is presence of gastric mucosa, all of these are going to increase the risk of complications. Clear guys? So
Yes.
this was Meckel's diverticulum, a small topic but very very important topic. Thank you listeners. Thank you very much for giving me
And
this opportunity to present this. Thank you.
thank you, sir.